Hi, a very good evening, each and every one of you. So before we start with our first session, please confirm the audio and video streaming. And this session will be a starter for quick revision classes. We are launching these quick revision classes with some specific objectives. I'll let you know what those objectives are and what you can expect from these sessions. And in the meantime, please confirm the audio and video streaming. A very good evening, each and every one of you. So last year, we started these revision classes subject-wise just before the exam. So this year, we are trying to do it in a much better way and in an advanced way possible. So we'll be having multiple quick revision classes. Each class will make sure that the duration is not more than 30 to 40 minutes. And in the process of revision, we'll focus on select points, select topics, select concepts, including case-based questions for your convenience, right? So we'll have these revision classes in the form of MCQ discussions. And in the process of you guys answering questions, I'll be reviewing some literature and will be providing you additional relevant information which you can make a note of. It's completely up to you. So my sincere request to each and every one of you is just make sure you are participating actively rather than passively going through what's being discussed here. Try to give out answers, make notes, and of course, you can always get back through mail for further discussion or to get any of your doubts clarified through our doubt clarification form. You're always welcome, right? So with this initial inputs, let me start with the objectives and then we'll move on to our presentation, today's presentation, right? Quick revision class from I've selected clinical subjects. First, we'll deal with clinical subjects and then we'll move on to basic subjects, or we'll do the combination of clinical and basic subject, which will try to evolve in the process of this discussion. Yeah, all good. That's fantastic to hear. That's always fantastic to hear. So first and foremost, before we start our first quick revision class, the following are the objectives. So that you'll have an idea on what you can expect from these classes. First and foremost, the objective is to discuss various important topics in entrance perspective, including case-based questions. Second, to enhance your confidence. These are revision classes. Instead of trying to discuss something new, we'll try to discuss things which we already taught in this entire year, and also we'll try to discuss various familiar topics. So one of the important objectives of these quick revision classes is to enhance your confidence, which you can do by yourself or through active participation. And so many of you are asking for several short videos, so keeping that request in mind, we'll try to keep these videos to minimum extent possible, 30 or 40 minutes maximum. So these several short videos, which we'll be doing in the coming days, will definitely, I hope they'll save your time, help you make most use of your time qualitatively, and also it helps us to focus on select specific topics. Right? And also, one of the objectives is to demonstrate that learning is fun, right? Fortunately or mostly unfortunately, during our undergraduation, preparation or study as such is considered to be a burdensome activity or, a kind of burden. But this is to demonstrate that learning is fun. Learning can be fun. It's all about our orientation. It's all about how we are discussing the subject and moving forward accordingly. And another objective is to promote active participation, right? So I request all of you to actively participate, even if you don't know what the answer is. Try to give out the answer. If you're right, that's fine. You'll be reinforcing the concepts. If you're wrong, you'll be learning, right? So learning is a never-ending process, isn't it? So try to actively participate and you're free to make notes. And even if you start making notes, at least from these revision classes, you'll get several key important points in entrance perspective, which definitely will enhance your confidence, right? So this is what I would like to highlight, right? So these are some of the objectives of our quick revision classes. So shall we start? So I hope you guys are all ready. So let's start our presentation now. Also, I've realized that there will be a lag of 20 seconds. Right now, when I say something, it reaches you after 20 seconds because we're trying to live stream from Zoom to YouTube. So what I'll be doing is when I post any question, right? There will be 20 seconds lag. I'll be utilizing that time to review literature and provide you relevant inputs, okay? If in case you feel like you're missing something, you can always watch the video once once the stream ends, right? We'll be editing the final version and all the waiting part will be cut and you'll be getting a final refined version of this video, at least 2 to 3 hours after the stream ends, okay? I hope you guys are ready. So let's start with our presentation, our very first class for 2021, quick revision class for 2021. So in this class, we'll deal with some select topics from conservative dentistry, clinical subject, right? Now, first question, statement 1 and statement 2. You guys have 2 statements. So go through the statements carefully and let me know which of them is right or wrong. Statement 1, class 1 cavities have a high C factor. Statement 2, when the composite restorations are cured, fluid-filled gap will be created below the restoration due to shrinkage stress. So what's your take on this? Both statements are true. Both statements are false. Statement 1 is true. Statement 2 is false. Statement 2 is true. Statement 1 is false. So as you know, C factor, configuration factor, is one such very important factor or parameter which has much clinical relevance, which we discussed previously as well. So configuration factor, it's a ratio of bonded to unbonded areas. So let me review some literature, and in the meantime, you guys can answer. So usually, I'll show you some illustrations. Small class 1 cavities, the C factor is usually higher. It's because they have huge bonded area and relatively small unbonded area. Remember, C factor is a ratio. So when these restorations are cured with composite, there is a high amount of competition for the bond, and the result is that the weakest bond, usually on the pulpal floor, gives away under the shrinkage stress, creating a fluid-filled gap below the restoration and high likelihood of post-operative sensitivity. These restorations should be placed for this reason in anatomical increments so that the material can shrink freely in one direction and thus eliminate or reduce the shrinkage stress. So incremental or layering technique to eliminate shrinkage stress or minimize shrinkage stress, which we already discussed in our C factor video. So you can refer to that video. Also, you can go through these illustrations, which I'll be presenting now. Yes. Both the statements are true based on what we have referred. And as you can see, we have some illustrations. Top left, you can see C factor values for various cavity configurations, starting from class 5. And as you move towards right, class 4, class 3, class 2, and class 1, right? And also on bottom right, you can see layering technique, how you can place composite through layering technique to minimize or eliminate shrinkage stress, which we discussed just now. So option A, as most of you chose, is the right answer. If you're right, that's fantastic news. If you're wrong, it's still an opportunity for you to correct and then enhance your knowledge accordingly, because the revision is all about enhancing one's knowledge through repeated practice, through a specific ritual. Now let's move on to our second question, an image-based question. Identify the wedging technique that's being projected in this illustration. Option A, double wedging. Option B, piggyback wedging. Option C, wedge wedging. Option D, singlet wedging. So which wedging technique this could be? You can see 2 wedges. One wedge is placed from the lingual side through lingual embrasure, and the other wedge is placed perpendicular to the previous wedge. So why do you have these wedging techniques? First of all, A, B, C, there are different types of wedging techniques. So you place a wedge with a specific purpose for closer adaptation of metric span to absorb saliva. They say even isolation if you're going for wooden wedges. So there are some specific uses of a wedge. I'm sure you know the theory, and you might have written volumes of the same during your university theory exams. So which wedging technique is being projected here? Yeah. So a double wedging is where you place 2 wedges, one from labial side and other from palatal or lingual side, when there are wider embrasure spaces. Piggyback, piggybacking, one wedge on top of other. So piggyback wedging. So when the embrasure space is more towards the cervical area, right? Yeah, and then wedge wedging technique. So as you can see, and as you rightly mentioned, wedge wedging or matrix, usually the second wedge is inserted either from lingual facial embrasure, whichever is larger. And most importantly, when do you go for this technique? Usually when there is concavity proximally. In such cases, like the mesial surface of maxillary first premolar, where you have fluted root and concavity on the crown, right? For better adaptation of the matrix band, right? We go for this wedge wedging technique. To wedge a matrix band tightly against such a margin, a second pointed wedge may be inserted between the first wedge and the band, as you can see in wedge wedging technique. The wedging action should provide enough separation of edge centi to compensate for the thickness of matrix band. And it's very important that the tightness of wedge, see, once you remove these wedges, right, there has to be positive contact, which is very, very important, right? So this wedging action ensures a positive contact relationship after the matrix is removed. I mean, without positive contact, again, there can be food lodgement, food impaction, secondary caries, gingival periodontal problems, and the sequelae. The tightness of wedge, this is very, very important clinically. Please do make a note. The tightness of wedge is tested by pressing the tip of an explorer firmly at several points along the middle two-thirds of gingival margin against the matrix band to verify that it cannot be moved away from the gingival margin. So use an explorer to verify its adaptation or tightness, right? The tightness of the wedge. So as you all rightly mentioned, option C, wedge wedging is right answer. And also you can see some additional illustrations where you can see double wedging left side and piggyback wedging on the right side. So double wedging, you can see wider interproximal embrasure spaces, two edges placed, one from buccal side or labial side, the other from lingual side or palatal side. Compound for supporting these wedges. Piggyback, one wedge on top of the other, right? So these are two illustrations representing the rest two wedging techniques. I hope it's clear. So always remember, studying theory is good, but through illustrative approach is much more fun and interesting. It adds flavor to our preparation. Going through just theory will be monotonous and demotivating experience, isn't it? Now let's move on to our next question, third question. So assertion and reason, let's see how many of you are going to get it right. So assertion states that patients with severe gag reflex may appreciate the use of digital impression more than conventional impressions. Reason, digital impressions do not need much of mouth opening in contrast with conventional impression taking. So go through this assertion and reason carefully and let me know which of the following options would you choose or is true. Assertion and reason are true and reason justifies assertion. Option B, assertion and reason are true and reason is not the correct explanation of A, doesn't justify. Assertion is false, reason is true. Both assertion and reason are false. So which of the following options would you choose? So let me review some literature in the meantime. Swati has already answered this question. Okay, so the relative size of the camera. I said before you choose the option, go through the assertion and reason again carefully. Always make this a habit, go through each question and all the options at least twice, minimum twice. So the relative size of camera may be a concern for patients with restricted ability to open their mouth wide. Generally, if there is a sufficient vertical space to complete the tooth preparation with dental handpiece, there is sufficient space for use of a digital camera. However, patients with severe gag reflex may appreciate the use of a digital impression more than a conventional impression since there is no physical contact with intraoral tissues by a tray or impression material when recording a digital impression. So now, which one would you choose? Very good. So both assertion and reason are true, but reason is not justifying assertion. Both are independent statements. Patients with severe gag reflex may appreciate the use of digital impression more than conventional because there is lack of physical touch. in the form of placing impression trays or impression materials, right? No physical contact whatsoever. So both statements are true, but reason doesn't justify assertion as, yeah, as you rightly mentioned. Okay, and the literature which I'm reviewing is from standard textbook, Sturtevant. So if you want, I can give you the edition, 7th edition, page 433. You can review that later at your convenience. Urvi, it's okay. You tried and you answered well. So you need not retract your message. Okay, well done everyone. Yes. Monica, there is no option of keeping a question mark alongside the option. You'll not have such options in the final exam. Right? I see you placed a question mark. Okay. Okay. Very good. As I said, if you're right, fantastic. If you're wrong, it's an opportunity for you to rectify, update, and enhance your knowledge accordingly. Now let's move on to our next question. Yeah, before that, you can see the illustrations, digital impressions, intraoral scanner, bottom right. Yeah. So no physical contact using trays or tissues. Obviously, this is modern technology for you. And I'm sure you'll be incorporating them in your practice without any doubt. Yes, of course, Arpana. Mouth opening is definitely required. Just go through the reason and tell me if it's justifying the assertion or not. Now, let's move on to our next question. The functional cusps are identified by the following except. In fact, we discussed elaborate on this. We had a separate debate session on functional versus non-functional cusps. I'm sure you guys can answer it. So the functional cusps are identified by the following except. They contact the opposing tooth in maximum intercuspation. MI is maximum intercuspation, not mission impossible. Option B, their outer or facial inclines have potential to contact or potential for contact. Option C, they are nearer the facial lingual center of tooth than non-functional cusps. Option D, they have broader, more rounded cusp ridges with lesser dentin support than non-functional cusps. So which one do you think is the right answer, or the more appropriate answer? Yeah. So I'll show you an illustration where we can clearly see some important characteristics of functional cusps. In the meantime, let me review some literature. Very interesting information about functional cusps. Why are you calling them as functional cusps? Why are you calling them as holding cusps? Why are you calling them as centric cusps? So functional cusps, the lingual occlusal line of maxillary teeth and the facial occlusal line of mandibular teeth mark the locations of functional cusps. These cusps contact opposing teeth in their corresponding facial lingual center on a marginal ridge or a fossa, which is very, very important. Functional cusp central fossa contact has been compared to mortar and pestle because the functional cusp cuts, crushes, and grinds fibrous food against the ridges forming the concavity of the fossa. Natural tooth form has multiple ridges and grooves ideally suited to aid in the reduction of food bolus during chewing. Functional cusps serve additional functions. Along with crushing, cutting, and grinding fibrous food, functional cusps also serve to prevent drifting and passive eruption of teeth. That's the reason why they're called as holding cusps. Very, very important. And the functional cusps are identified by 5 characteristics. They contact the opposing teeth during maximum intercuspation. Option A. They maintain vertical dimension of face, which is not mentioned here. They are nearer to facial lingual center of tooth than non-functional cusps. Option C. Their outer or facial incline has potential for contact. Option B. So you got the answer. Option D. They have broader, more rounded cusp ridges with greater dentin support compared to non-functional cusps. Option D, as most of you have chosen, is right answer. In the meantime, just go through this illustration. So maxillary arch is larger than mandibular arch, as you guys are aware of. The functional cusps are located on maxillary lingual occlusal line, as you can see in this illustration. Whereas in case of mandibular teeth, the mandibular functional cusps are located on mandibular facial occlusal line. And you know what? The interesting thing here is the lingual tilt of posterior teeth. You know, the lingual tilt of posterior teeth increases the relative height of functional cusp with respect to non-functional cusps. And during fabrication of restorations, clinically relevant point, it is important that the functional cusps are not contacting opposing teeth in a manner that results in lateral deflection. Rather, restoration should provide contacts on plateaus or smoothly concave fossa so that the forces of mastication are following through the long axis of the tooth and are better absorbed by your periodontium, and to avoid lateral deflections as mentioned here, right? So consider this very, very important, especially the characteristics of functional, non-functional cusps. And as you can see in this illustration, synonyms of functional cusps, I think it's not so clear. Yeah, centric cusps, holding cusps, stamp cusps, and you can see functional cusps in mandibular arch as well as in maxillary arch, and also you can see the lingual tilt 20 degrees, which increases or which makes sure that these functional cusps are contacting, right? Yeah, this increases the relative height of functional cusps compared to non-functional cusps. Okay, now, yeah, you can review this information. It's available in Students, and if you have any further queries or you need any further clarification, of course, you can always get back through mail 24/7. Right, now, fifth question, I would say penultimate question. 1% solution of sodium nitrite is, so which one would you choose among the given options? Bleaching agent, sterilization solution, disinfectant, anti-rust agent. So what's your opinion? 1% solution of sodium nitrite is, what would you choose? And another related question or an add-on question, is it sodium nitrite or is it sodium nitrate? Even having clarity in that is equally important. So what is this 1% solution of sodium nitrite? So I'll be citing literature from different standard textbooks and articles. So one of the disadvantages of autoclaving is rusting of instruments, which can be reduced by dipping instruments in 1% solution of sodium nitrite for 2 minutes before autoclaving. And in one of the textbooks, it's mentioned that burrs can be protected by keeping them submerged in 2% sodium nitrite solution. Also, they mentioned about spray rust inhibitor, which is nothing but sodium nitrite on the instruments. And also have some PubMed indexed articles. I think this information would be suffice. Okay. Now, let's conclude with this. I'm not going to answer this question because you guys are going to answer with relevant explanation, and we'll start our next session. The next session, when we start the other day, we'll start with this case-based question. So you can consider this as your homework question and solve it in the meantime. And when we start our next revision, quick revision class, we can discuss. We can start with this question discussion. So case-based question, a patient returns to your clinic 24 hours. You don't want that to happen. Frankly, you don't want that to happen. But anyways, not everything is in our hands. A patient returns to your clinic 24 hours after you cemented a gold crown in relation to 3/6. Patient complains of sharp electrical sensation in both upper and lower jaws on left side. Patient has amalgam restoration in relation to 2/6. This sensation, which the patient complains of, could be due to option A, electrolyte explosion, option B, galvanic shock, option C, tarnish, option D, electromagnetic pulse. So which of the options do you think is more appropriate? And most importantly, why? So I see most of you choosing a specific option. So why do you think it is that specific option? So let's start our next quick revision class with this question. In the meantime, try finding out, review some literature, make notes, and then we'll definitely incorporate questions in this format, right? So as I mentioned, the objective of quick revision class is to save your time and also to enhance your confidence. I hope the objectives will be met, and consider this case-based question as your homework question. Okay? Okay, guys, so it's really good to see. Yeah, it's really good to see all of you actively participating. I'll definitely review your answers. Of course, you can answer this. It's up to you, but your answers are invalid because I'll be asking you the same question in the next session. But I really appreciate your enthusiasm. please come up with an explanation. Why one specific option? Consider this case-based question as your homework question. And as I said, consider this as a model quick revision class. We'll try our level best to incorporate more and more quick revision classes for your benefit, and also see to that we are providing you important relevant topics in this process, right? I hope you enjoyed this session. And before I conclude, just make sure that you're giving your best. And irrespective of how many are taking up the entrance or how the exam is going to be, all those factors don't matter as long as you're focusing on giving your best towards the task at hand. That enables you to do things in a mindful way, without stress or much pressure from your past bad memories or future negative expectations. And let me conclude with this. Okay. I hope the session is useful. And every revision class, I'll update you guys at least 5 to 6 hours prior. I think that would be suffice for you to get ready, right? And also it helps me to decide whether I can conduct a revision class or not. As I said, because of my personal challenges, so I need to manage certain other things. But as I said, I promise you guys to conduct as many revision classes as possible in this particular format, and will definitely incorporate case-based questions as well. You have any queries, you can always get back through mail at proudtobedentist@gmail.com, and you can use a doubt clarification form to get all your doubts clarified. Okay, so please keep smiling. And before I conclude, one final thing which I wanted to highlight is other external things which are happening in our life. I mean, some things might be in our control, some things might not be in our control, which is absolutely fine. We should understand this. I mean, we should actually think about this and try to understand this, because often we assume that everything has to be under our control, which never almost happens. Not everything is under our control. I'm talking about the external factors. But what's happening in here, how we are perceiving things, how our perspectives are being developed towards certain things is absolutely in our control. So how you look at things really matters for you. So make sure you're taking care of that, and just keep this in mind that even though other things are not in our control, what's happening in here, your brain chemistry is well in your control 100%. When everything within here is in your control, don't you think your life would be a joyous experience? Of course, yes, without any doubt. So wish you all the best, love you all, and we'll definitely have more revision classes in the coming days. And I'll update you guys through our updates group, Telegram and Google Updates group, at least 5 to 6 hours prior. Right. So wish you all the best. Love you all. Take care and good night. Yeah. So yes, Vaishnav, definitely we'll have image-based questions too. We'll have an exclusive session on image-based questions too. I mean, give your feedback. Let me know what you want. Just throw your feedback. Whatever I can consider and incorporate in the coming sessions, I'll do it accordingly, without any doubt. Okay. Yeah. How many hours to study in the last month? Ankur, 24 hours a day would be the best answer, but it's not possible, right? So maximum time that's possible. I mean, my best was around 9 to 11 hours. So it's up to you, depending upon your other responsibilities. It can be 12 hours, it can be 6 hours, it can be 5 hours, but it has to be customized. That is maximum amount of time that you can allot towards preparation. If you have other responsibilities, see if you can hold on to them or postpone them to a later day, but allot maximum time towards preparation. Ankur, this is not fair. All these general Q&As you're supposed to ask on Sunday in weekly Q&A session. Okay? Yeah, I'm just kidding. Yeah, sure. 5 a.m. sessions. Yeah, you guys decide. You guys decide whether you want 5 a.m. sessions or not. From my side, at least, I'll make sure I'm posting questions, quiz-related questions at 5 a.m. in study club. I mean, if you guys want to discuss, please let me know. I will have the sequence of subjects, and then we'll allot you subjects so that you can decide, share questions as per your convenience. It's all up to you. Yes, Sriparna. Yeah. Yeah, we'll definitely have either a clinical or a basic. And in the coming years, if possible, we'll try to mix both of them. Definitely. Any chance of postpone? I don't know, Sachin. As of now, it's December 16th. Okay, yeah. If at all there is any update, we'll definitely let you know. Okay, guys. You have any queries? I really appreciate your enthusiasm. Please get back to me for any further queries or clarification. Yeah, take care. Bye.